So is fascia an organ system, or is it just packaging material? Now, we've had a few hundred years of anatomical advances, medical discoveries. So why is it that an entire organ system went unnoticed, unexamined, and why are we suddenly obsessed about it now? So hi, I'm Dr. Darren, a clinical anatomist, and I like making medical animations and illustrations to talk about theoretical anatomy and share what I know. So in this short lecture series, I want to talk about fascia, and in this video, I will be talking about why is it difficult to understand fascia, what is the emerging link between fascia and pain, and a small segment that I've called pragmatic prisons and myofascial continuums. So why is fascia difficult to understand? Now, to dive deeper into this, I'd like to first start with heuristics. Now, heuristics is a word that talks about, mental shortcuts or academic shortcuts in a sense, which sort of persists. So some authors have raised the issue that, because these dissection manuals constantly talk about cleaning and discarding fascia, it creates a sense of bias that when you try to approach your dissections, you don't really tend to pay attention to what you're seeing. So this was also the frustration that I had during my, I would say academic dissections during postgraduate training, where I noticed that, every single time the approach to structures were quite difficult because most of the authors would always state clean the fascia. And I think this kind of a perception of fascia as a connective tissue has continued. The second reason why it's difficult to understand fascia is terminologies. Now, some authors have raised this issue as well, where they claim that a lack of standardized nomenclature fragments our perception of fascia because different medical practitioners, anatomists, surgeons begin to describe fascia in a way that makes sense to them. And, there are several terminologies like superficial, deep fascia, which is now, the most recent one is the term hypodermis. And once again, when we look at fasciae in different regions of the body, we tend to use regional terminologies. So this creates a kind of a man-made, a man-made structure to think of fascia, which is not really helpful when we want to pull all of its functions together. The last reason why fascia is difficult to study is because of a lack of tools to study its three-dimensional nature. So a very recent article that was published, the authors claimed that they are the first ones to describe the ultrastructure of the deep fascia, and they were able to demonstrate that the deep fascia is made up of 3 layers. And that's pretty cool because it begins to raise the question, does conventional histological preparations allow us to appreciate fascia? And the authors also give some kind of some evidence to show how limiting conventional histological preparations are, like hematoxylin and eosin staining techniques, because they claim that it leads to some kind of tissue shrinkage and artifacts. And that's quite true because if we also reflect on our own explorations with dissections, the moment the skin is reflected, the moment planes of separation are created, we tend to lose a lot of that three-dimensional framework of fascia, making it very, very difficult to understand what fascia is all about. So is pain all in your head? Now, there is emerging evidence to link fascia to pain. And in this part of the video, let's see how that happens. So some authors have raised a very interesting problem, and that is the development of post-surgical pain. So I've taken the statistics and the references below over here. And if we look at this table, the first column lists the different surgical procedures, and the second column lists the incidence rates of post-surgical pain. And if you look closer, the variation of post-surgical pain is quite large in some of these surgical procedures. So the authors question what could be the reason for this wide variation. And the other point that they raise is in terms of the therapeutic modalities that are available for such patients, there are quite a bit of failure rates that are seen. Not everyone is happy with the treatment that they get for pain. So why is that? Now, the best model that has been raised to explain the development of post-surgical pain, or even conditions like fibromyalgia, is the neurocentric model. Now, before I talk about the neurocentric model, I also want to talk about fibromyalgia. And fibromyalgia essentially is a condition where the patient, experiences diffuse pain that cannot be linked to any underlying structural cause. And this does present itself in later decades of life, and is a burden on the healthcare system because a lot of patients complain of pain, and the therapeutic modalities that have been explored so far seem to provide unsatisfactory results, because although there are some who respond to pharmaceutical interventions that target pain pathways, others do not, and this creates a problem. Are we missing something with the neurocentric model, or is there something hiding? So if we look at the neurocentric model, what it essentially means is that there is we can link the causation of pain towards the nervous system. So some theories like the central sensitization theory, psychosocial influences that that lower the threshold for perception of pain, or even something like a neuroma formation in surgical sites. So all of this has been proposed to be linked towards the causation of pain. However, coming back to the issue of the therapeutic interventions that have been used so far, there is again the spectrum of patients who either respond or don't respond to this treatment. So in the background of this, there has been several studies, several articles, several authors who have raised the issue and perhaps try to ask, is all of this linked to fascia? So to make sense of this, I've made an animation. And if you see here on the screen, on the left is a jelly-like block where the jelly-like substance represents the ground substance and the white fibers within it are the collagen fibers. And passing through this jelly-like block is a small segment of a nerve fiber. And on the right is a zoomed up version just to, give you that appreciation of space. Now, I'll just play the animation and notice what happens. So with time, there is an increased deposition of collagen fibers, thereby making the fascia thick. So let's just go back to the starting point. So let's assume that this is normal fascia and there is some kind of a biomechanical equilibrium that the structures within the fascia are, involved in. So none of it is influencing the other a little too much. So the collagen is just hanging around, the nerve fibers are passing through it, and everything seems okay. Now, after some kind of a surgical procedure or some kind of facial dysfunction due to any kind of lifestyle issues, the fascia begins to become thickened or dense, and that is what I wanted to show with the animation over here. So if we play it again, see how the fascia thickens and there is collagen deposition or also remodeling being postulated in the structural basis of pain. So what happens at the end state once the fascia becomes dense is that the biomechanical properties, right, have changed. So there is a possibility that the fascia becomes more rigid, more tense, and this tension in some way will stimulate the nociceptive fibers and the nerve fibers passing through it, which leads to the causation of pain. Another interesting fact to support this claim is that recent evidence has shown that fascia has a rich supply of nociceptive fibers and proprioceptive receptors, which some authors have also claimed that they are either equivalent or more in density to that found in skin. So this raises quite the the suspicion of fascia being linked to pain. I mean, having so many receptors cannot mean that the fascia is just behaving as a connective tissue, but there is a high chance that a lot of this has a direct role to play in the pathophysiology of pain. Pragmatic prisons and myofascial continuums. So before I get to what pragmatic prisons mean, I'd like to share my personal experiences through my dissections. And during my post-graduation, I think the one structure that fascinated me a lot is fascia, and simply because a lot of the dissection manuals that I pored over, or the kind of surgical approaches that I read about, barely described the structural makeup of fascia. But this is not where it stops. As my dissections progressed, I started noticing that the fascia formed beautiful patterns. And I like to think that whenever we see a pattern in the human body, I don't think it's coincidence. Rather, there must be some kind of a structure-function correlation that is hiding behind it. So I'd like to take the example of one of my dissections. What you're seeing here is a dissection of the extensor aspect of the forearm, and I was trying to study the extensor retinaculum. So if I zoom into this, I want you to appreciate how the deep fascia slowly merges into the extensor retinaculum. Now, as I was proceeding with this dissection, I had a few thoughts. One of it was, at what point do we actually say that the extensor retinaculum is its own structure? Because most academic publications will talk about the extensor retinaculum as a tense band of tissue, right, that is present in the extensor aspect of the wrist. But when we look closely, we can see that all of this fascia is enmeshed together. So I was wondering whether there is some kind of a biomechanical, difference that is there with this interface part, where the deep fascia is slowly merging into the extensor retinaculum. Because if we were to assume that the extensor retinaculum is a band-like tissue, then that creates the impression that all of this interface material is inconsequential. But if we look closely, if we look closer at the deep fascia, at that interface, we start seeing a slow blend, slow merge. So does it mean that functionally there is something going on at that interface zone and maybe we're not paying attention to it? So that led me towards discovering more literature on fascia. And as I started reading, I started noticing that there was this term called as myofascial continuums being pushed around in modern literature. And I really loved it because it sort of helped me make sense of some of my observations through my dissections. And that is, it always looks like there is a continuum in the body. And everything that is dissected is just an artificial process, right? Which is either made to study the structure or from a surgical point of view to help the patient. But coming back to this kind of continuum, right? What myofascial continuum essentially means is that there is a kind of structural continuity between the fascia and the muscles of the body. So there are around 6 types that have been put forward. So I'll just talk about one as an example, and that is the superficial backline. The idea behind the superficial backline is that it starts in the ankle, the tendocalcaneus, passes through the gastrocnemius, the soleus muscle, from there via the hamstrings, the sacrotuberous ligaments, the gluteal muscles, the rectus spinae, the extensors of the neck, the epicranial fasciae, the thoracolumbar fascia over here in between. So all of these structures form a continuous kind of continuum. And there has been both anatomical and functional evidence for this. From the anatomical standpoint, most of the evidence comes from robust cadaveric dissections that demonstrate a kind of structural continuity, right, in terms of the adhesions between all of these structures described. Whereas if we look at the functional evidence for this, ultrasound has been used, or magnetic resonance elastographic studies have been done to see how are the biomechanical properties of this fascia. Some authors have also claimed some very exciting things. For example, this paper discussed that the fascia might probably cause around, or probably be involved in around 30% of biomechanical load transmission. Now, 30% is quite a huge number, because if we contextualize this within the the process of surgery, we tend to start thinking or seeing a problem present itself. That is, the moment the fascia is disturbed, the way the biomechanical forces that should have traveled through the body, are also disturbed. So, is it possible that any kind of manipulation then leads to a problem where the forces are, not traveling the way they should? The kind of equilibrium that the nociceptors that enjoyed, up to the point where the fascia was healthy, has now been disturbed. So, is it possible that this is also a cause for fascia and its link to pain? Lastly, I want to talk about why I titled this segment as Pragmatic Prisons. The reason why I use the word pragmatic is because I'm not trying to say that, we shouldn't use the terminologies that we have so far to describe fascia, because it does help, different medical professionals solve different kinds of problems for patients. So there is a use in, fragmenting anatomy, and that use is pragmatic. The reason why I use the word prisons is because if we stick too much to some of these descriptions, then it tends to prevent us from looking at, all of the other possibilities of what could have been. Essentially, it creates this illusion that we know everything we need to know about anatomy. And maybe I've presented enough evidence now to show you that perhaps we don't. So in this video, we saw how it was difficult to study or understand fascia, why it has been, such a long time because of a lack of different kinds of techniques, different terminologies. Then we examined possible links between fascia and pain. And I showed you that cool animation to show you how diseased fascia can, unprovoked, stimulate the nociceptive receptors within the fascia. And then we spoke about some, theoretical aspects of what I call pragmatic prisons. But of course, I was able to show you the myofascial continuums in the body and how those matter. A lot of manual therapists do tend to use this to help in pain relief for different kinds of patients. And with that, we come to an end with this lecture. In the next one, I'll be going in depth into more of the structural basis, more animations. I will talk about the various cells that we see in the fascia. We'll talk about how fascia has varying properties depending on its location in the body, the different kinds of disease processes involved, and also look at a very exciting concept that has been put forward, and that is the interconnected fluid network that is created because of the way fascia is laid out throughout the body.